care, but this is really thinking
This
about
meeting is being recorded.
what we can do in the sense of primary care in keeping patients' livers healthy. Please stop me at any time if you have questions. The goals of our talk today is to talk a little bit about the causes and outcomes of chronic liver disease, review very briefly hepatitis C treatment, review vaccination of hepatitis A and B, explore alcohol use assessment and possible interventions, and talk very briefly about surveillance for hepatocellular carcinoma. For the leading causes of chronic liver disease in the US, I know we have a small presence on this call internationally, but I'm speaking here about the United States. Liver disease is the 8th leading cause of death, 2 million deaths a year, and this is mainly due to hepatocellular carcinoma and cirrhosis. Those are what we're trying to avoid at all costs, and that is mainly caused by viral hepatitis, which I know is the focus of our ECHO group, hepatitis B, hepatitis C as well, and non-alcoholic fatty liver disease and alcoholic liver disease. So, of course, we think of these illnesses as each their own diagnosis, but many patients could have one or more of these illnesses and make their liver even more at risk for a poor outcome. So I'm just going to show a few natural history or progressions of liver disease. I'm first going to talk about hepatitis C. I know that our ECHO has been focusing on hepatitis B, so I thought maybe it would be a good time to bring up a few points about hepatitis C, because often patients can come in with both hepatitis B and hepatitis C co-infected. So most patients that have hepatitis C go on to have chronic hep C, but 15 to 25% of patients will spontaneously cure hepatitis C on their own or never have chronic hepatitis C. And this happens early on in the infection, so it won't be years later, but months after being exposed to hepatitis C. And after having hepatitis C for a long time, after having that inflammation in one's liver, it can go on to develop fibrosis, which leads to cirrhosis. And then the two outcomes that we're trying to avoid at all costs in every liver problem is hepatocellular carcinoma and hepatic decompensation. So hepatitis B, which we have talked a lot about, is has a progression to cirrhosis, hepatocellular carcinoma, and cirrhosis, but it's a little bit different. As we've learned, having a chronic hepatitis B infection can lead to liver cancer on its own. You don't have to necessarily go directly to cirrhosis and then cancer. So as we know, we're screening all of our patients with hepatitis B for liver cancer, or HCC, hepatocellular carcinoma. So the natural history of non-alcoholic liver disease, this has come up a little bit in some of our cases. There is a genetic a predisposition to get this type of liver disease. It also can be caused by diet. They're doing studies to see if it's related to high cholesterol. So all these things can be occurring with a viral hepatitis or on their own, and it can lead to a poor outcome of cirrhosis or cancer. The natural progression of alcoholic liver disease is very similar, but when folks stop drinking or reduce their alcohol intake, there can be some reversal. So you notice in this diagram, there's some beautiful green arrows going backwards, whereas in a lot of the viral hepatitises, we think of it as damage that's going to continue to build on top of each other and progress. In the case of alcoholic liver disease, there can be some regression, which is really hopeful and a place that we can do an intervention as clinicians. So I wanted to speak a little bit about viral hepatitis, what we can do to prevent it. Of course, we need to be screening all patients for hepatitis B and hepatitis C. We've talked a lot about getting universal screening approved, and as we're testing for hepatitis B, don't forget to test all patients for hepatitis C. It's important to use the test that reflexes automatically to a viral load so that that test can be confirmed immediately. I don't think too many clinics are just doing antibodies, but that's just one note to be sure that the only test that you're offering is a reflex to confirm whether a patient has chronic hepatitis C or was able to either clear it on their own or has been treated. Immunize as needed. We've talked a lot in this echo about how immunization is not recommended in isolated hepatitis B core antibody because most of those folks have been exposed to the virus. All patients with an active chronic hepatitis C infection should be referred for treatment. If you don't treat in your clinic or in your health center, it's really important to have a relationship if you're a hepatitis organization to know where patients can go to receive hepatitis C treatment. And of course, to treat and monitor all chronic hepatitis B patients. So the next few slides are about hepatitis C, just because we don't often talk about that in our hepatitis B echo. It's important to know that with the onset of direct acting agents or DAAs for hepatitis C, that treatment can be in a lot of different scenarios. So treatment isn't just in specialty offices, hepatologists or gastroenterologists. Folks can go get treated for their hepatitis C in a variety of settings. They're starting to treat in Pennsylvania in the prison setting. A lot of methadone clinics are starting hepatitis C treatment. Advanced practitioners like myself, a PA or an NP, can treat hepatitis C. Pharmacists in some settings treat hepatitis C. So it's important to realize that it's not just a specialty referral for patients living with chronic hep C. What we're going for with hepatitis C is a sustained viral response, a cure. So unlike hepatitis B, where cure rates are really low, cure rates are really high with these new direct acting agents for hepatitis C. So the benefits of achieving an SVR or a sustained viral response or a cure is first of all decreased transmission. It's really important to recognize that the more folks that we treat and cure for hepatitis C, the less it will be transmitted among our communities. Of course, it's reducing the risk for cirrhosis and decompensation. And it also has been shown to improve all-cause mortality. Other causes of death improves risks of diabetes, heart disease, and kidney disease. This is just a brief slide about the treatments. These are the direct acting agents that I referred to. Mavorite is the brand name, and Epclusa is a brand name of two medications that are most often used. They're easy to take. They have more than a 98% chance rate of efficacy if patients are naive, meaning they've never been treated before. So this is a really exciting development in hepatitis C over the past 5-10 years. And I want to be sure that everyone knows about this because it's pretty satisfying and also exciting to have a cure for a viral hepatitis. Hopefully we'll be having the same news about hepatitis B in the future. So I have a few questions throughout this presentation, and the first one is who should be treated for hepatitis C? I know I mentioned that everyone should be treated, but I wanted to emphasize that. I wanted to emphasize that people who are actively injecting or using any type of substance should still be treated for hepatitis C. In fact, those are the patients that we need to be treating in order to work towards elimination of hepatitis C in our community. Patients who have other comorbidities can still be treated for hep C. It's really moved from, like I said, a specialist, difficult illness to cure to something that's much more curable. So I'm going to pause here, ask if there's any questions so far about what I've shared, and ask if there's any opinions around treatment for hepatitis C.
Katie, this is Tanaja.
Thank
Do you often use Vosevi, or is it just for folks who might have reinfection? I've
Yep.
heard different things.
Yeah, folks who are reinfected, I have never used it as a first-line treatment. I like to tell patients that, you know, there's a 98% chance they should respond to these medications, but there's always a backup in case they say, what if? And there is a backup for people that don't respond to one of the first two agents, or if there was a pause in their treatment or trouble treating with one of the other agents. I've used Vasevi probably 2 or 3 times in the past 2 years, but not often.
Thank you.
It looks like we have a comment in the chat or a question. So you said it's common to have co-infections in patients with hepatitis B and also hepatitis C?
Yes, it can be. I work, like I said, in North Philadelphia, so a lot of my patients are being exposed to hepatitis B through injection drug use or sexual risk. Um, so those are sometimes risk factors that also mean people have been exposed to hepatitis C. All right, so I hope that you get the take-home point that all patients should be considered for hepatitis C treatment, even if folks are actively injecting or using substances, especially if they have other liver diagnoses or any other things going on with their liver. It's even more important to treat their hepatitis C because that's something that can be done in a short amount of time, um, at least in the United States.
Katie, oh, sorry.
Yep.
Looks
Go
like we
ahead.
had another question in the chat. It was just, what is the main distinguishing factor between hepatitis B and hepatitis C?
It's a good question. They're both viral illnesses. Hepatitis B enters into the D as a DNA virus, so it's a little bit different in its mechanism of infection. Hepatitis B doesn't have a cure right now. I think a very small percentage of people can lose surface antigen, but most people keep it even if they're controlling the virus, whereas with hepatitis C, it can be cured. Hepatitis B folks are at risk for cancer regardless of fibrosis or cirrhosis, and hepatitis C patients are only at risk for cancer if they have advanced disease. So those are the things that first come to mind. But if there's anyone else on the call that would like to share any differences that they know, that would be great.
Katie, I completely agree. I think, as you pointed out, the hepatitis B virus having that covalently closed circular DNA, that little micro chromosome, if you will, that remains within the patient's liver cells, that really allows it to persist and reactivate over time. And hepatitis C does not have a corollary structure, hence you're able to eradicate it with these treatments. So really, I agree with that distinguishing point.
And just an additional, like for Hep B, there's also a vaccine, so we can prevent hepatitis B with the vaccine, and there's not one for Hep C either.
Great, thanks. So that leads right into our next part, which is vaccination. I know we've talked about a little bit about Hep B vaccination, but I wanted to think a little creatively about how we're vaccinating folks. One thing with COVID-19 that has improved or added to our vaccination process in clinics and in the community is having pharmacies involved. So I know before COVID, we had a hepatitis B vaccination finder of pharmacies in Philadelphia. And that was kind of a novel idea. And now it doesn't seem that novel because a lot of folks are going to pharmacies for COVID vaccines. There seems to be more advertising at pharmacies around the zoster, the shingles vaccine. So I think those two diseases have helped lead the way to also adding on hepatitis to the pharmacy vaccination process. I don't know how pharmacies are marketing that. They might not be, but patients can, if they don't want to make the trip into the office, can get vaccinated for hepatitis A and B in pharmacies in most cities in the United States. We have been using the vaccine registry more due to COVID-19, so we've been trying to update patients' vaccine records, and I think that's also has been a benefit of having the COVID vaccine and kind of looking at the vaccination screen in patients' chart more often. A few other caveats about vaccination: younger patients are more likely to respond. I don't have an exact date. I know it's in the 80s. If anyone knows when we started vaccinating babies, I think it was the late 80s, maybe 1989. But sometimes when I look at patients' date of birth, you can kind of know if they were born before that, they weren't vaccinated at birth. And so it would be something that you can have a conversation about screening and vaccinating as needed. Another caveat to vaccinating is that not everyone develops a surface antibody or a response to hepatitis B vaccine on the first try. If if folks are immunosuppressed, like having HIV, or if they're on hemodialysis. I think also diabetes, I didn't list that here, but I think that's also a risk factor for not responding to vaccination. You can do the whole series for hepatitis B again. I know that if they're having to have done the series twice, you can check to see if they responded. You can also give a double dose. If anyone has any more wisdom around vaccinations, I would love to hear it. These are the formulations of hepatitis B vaccine. I know we've gone over these before. Heplisav being the most trendy, also the most expensive. It's only 2 doses. And this is the Hep A vaccine schedule. So the second question that came up when I was thinking about vaccinations was if folks are deemed not immune, if they do not have the surface antibody to hepatitis B, and you decide to treat them as adults with a vaccination for Hep B or Hep A, do folks check to see that they've responded to be sure that the vaccine worked and if they need or don't need a second round? I don't know the answer to this question. I was asking it mainly for discussion. But if anyone has any insight, you can add that now. For me personally, when I have a patient who's living with HIV or a patient who is at high risk for hepatitis B, I usually check it again. If I know that they're an adult living without surface antibody, I'll try to remember. I think the official recommendation is a month after finishing the series, but usually it's whenever we do their labs again, I just check to see if they responded.
And it looks like that is also echoed in the chat as well. If they're at risk, certainly vaccinate. And it looks like Tanaja also mentioned that the Advisory Committee on Immunization Practices started recommending administration of hepatitis B in 1991 to all babies. Though 91. It was, I think it was approved before that in the 80s, but I think it was officially recommended in the 90s, and then there were catch up as well in like 1997 or something like that.
Great, thank you. Thanks, Tanaja. So our next topic to review is alcohol. How much alcohol is too much? So we don't have to stop and answer that question right now, but alcohol is a legal substance, as we know. So sometimes it's difficult to know when someone may or may not be, I wouldn't say abusing, or maybe have an alcohol use disorder. I think one of the biggest things that comes up in my practice is talking about the difference between beer and liquor and wine. Sometimes I'll use the word alcohol and ask folks how much alcohol they've had or if they drink alcohol, and they'll say, no, I don't drink alcohol, I just drink beer. No, I don't drink alcohol, I just drink wine. So a lot of folks in our community associate alcohol with liquor. And so I have a sign that shows in my office that all of these are equivalent. It doesn't really matter how the alcohol is being given or how the alcohol is being drunk. All of it is a risk factor for drinking too much. How much is too much? The Department of Health and Human Services say that adults of drinking age should not drink more than 2 drinks a day for men and 1 drink a day for women. So that's pretty conservative. The National Institute on Alcohol Abuse and Alcoholism has a different guideline. They say for men under between 21 and 65, shouldn't drink any more than 4 drinks on a single day or 14 drinks a week. So the 14 drinks a week kind of lines up with the 2 a day that the DHHS guidelines recommend. For women, they associate women and men older than 65 in the same category, and it's no more than 3 drinks a day and no more than 7 drinks a week or 1 drink a day. So how do we determine how much patients drink? When I was in PA school, we learned to ask a patient how much they're drinking a day and then take that times 2. That's about the only tool we were given. In general, how do you measure if someone's drinking too much and what is too much? So in the past few years, there's been a push for alcohol SBIRT or SBI, screening and brief intervention. And so what this is in a primary care setting or in a quick brief, healthcare setting of any sort, it could be in the ER, patients are asked a few questions and then given a brief intervention. So do you drink, and then some type of reaction. So there's different sets of screening questions to assess this. And the one question screening is, how many times in the past year have you had, for men, more than 5 drinks a day, and 4 for women? And if they've said, in the past year, I've done that too many times to count, that's likely someone that needs to be referred for treatment. The question obviously has its downfalls. It's estimating that someone's going to remember how much they've drank in the past year. So that's kind of difficult to start with. It doesn't account for chronic low-level drinking. Maybe they have 3 drinks a day, every day for the past year. So the question isn't great, but if you're going to have time to ask one question, that's the question that's recommended. There's other screening tools such as the audit, either 1, 2, or 3 questions. And there's the audit 10, which is pretty intense or thorough evaluation. And then the goal is to screen any of these screening tools and then intervene with a brief intervention. And the brief intervention can be, do you ever think about stopping to drink? What motivates you to do that? In our setting, in a federally qualified health center, we have behavioral health consultants who can give a few resources or just kind of start that relationship about alcohol conversation with the patient. But intervention can look different in different clinics. Folks can be referred to inpatient or outpatient treatment, to meetings, alcohol anonymous meetings. There's also medications that can be used to reduce alcohol use. We use a lot of Vivitrol in the clinic where I work, which is once a month. And this medication is brand name Vivitrol, generic naltrexone. The naltrexone generic form, it can also be given as a pill once a day. And this is for people who've already stopped drinking. It helps them maintain their sobriety and helps with cravings. There's other drugs that can be used, prescribed, if patients have contraindications to naltrexone. And when I think about talking with patients about alcohol reduction, I think about harm reduction. Like I said, I work in North Philly with a lot of patients who inject drugs. And so we talk a lot about harm reduction and the idea that harm reduction is any positive change. So people may not be able to stop drinking completely, but reducing their alcohol intake is a step in the right direction. Harm reduction as a principle is minimizing the harmful effects of drugs and alcohol rather than ignoring or being judgmental. So we try to really work at helping patients be honest about their alcohol intake and then set realistic goals at working to reduce or stop alcohol use. So we've talked a little bit about this test. It's called PEth, phosphatidylethanol. It's a lipid that forms in the body when it's exposed to alcohol. It's very specific for ethanol use. It doesn't come up positive if another substance is taken. I think it's trying to fill a gap at really assessing how much patients drink. Like I said, often patients aren't completely honest. Alcohol is a legal substance, and so it's sometimes a blurry line about how much is too much. So this is a test. I honestly don't use it in practice, so I'd be interested if anyone else on the call does. It can be a screening tool to estimate alcohol intake in the past 2 weeks. And usually alcohol isn't measured in urine drug screens, like the type of urine drug screens that we use when we prescribe Suboxone, or even for drug screens for employment. So people don't often measure alcohol, and I think this is trying to fill that gap of making a medical clinical assessment about alcohol use. We like to think that we are able to have an effective history taking with our patients and that it's an honest, safe place for people to talk about substance abuse, including alcohol, but sometimes that's not the case. But if anyone has any experience using this tool, I would love to hear about it.
Katie, I could share my limited experience. I've started to do this as a result of some of the discussions on these echoes as well, particularly in patients who are having trouble remembering what type of alcohol use patterns they've had. And I think as Dr. Gish had referred to this in the past, almost like a hemoglobin A1C for alcohol use, or monitoring over time for that alcohol use. And so in a handful of people who are motivated to change, but not sure, where things stand with regards to whether or not their alcohol use is making any headway. I'll use this, but I think to your point of the tools for intervention, it's these behavior changes and people who don't really feel that a quantitative value is going to help motivate them. I really look to other tools to try and help intervene.
Great, thanks. Yeah, that's helpful. All right, so that's the end of the conversation around alcohol. I had a few more points I want to make before we wrap up. When we think about general liver health, a lot of times I'll be giving patients the diagnosis of cirrhosis, and we treated their Hep C. They may or not have hepatitis B, and they're doing everything they can. And people want to know, what else can I do? How else can I keep my liver healthy? We always think you need your liver to live. You only have one liver. Very few patients are eligible for transplants. And so how can patients keep their liver living longer? And there's not too much, honestly. We can tell patients not to overuse Tylenol. I usually give the guideline of 2 grams a day, not to take high doses of iron supplements. It's important to review medications if someone has hepatic impairment to be sure we're not stressing their liver more with certain doses of medications. And then a risk for Vibrio, which is, I believe, a parasite, an infection. When I do send patients to the hepatologist, they usually come back with avoiding Vibrio infection, and the indication is no swimming or wading in non-chlorinated water in the Gulf of Mexico. So I really kind of chuckle when I see this on patients from North Philadelphia who might be at risk for Vibrio infection, but it also can be transmitted in raw seafood. And you might think just sushi, but also oysters. So this is what I know about Vibrio. And it is important to tell patients about it, but it's not always something that patients are at risk for if they don't live near the Gulf of Mexico. Anyone else have any suggestions for how we can keep our liver healthy beyond what we've already talked about? Okay, if anything comes to mind, just interrupt me. Lastly, I just wanted to mention cancer surveillance. I know that we've talked about this ad nauseum, but I wanted to also add another slide because I feel like it's a really important role for primary care for folks that are in hepatitis advocacy groups. The one thing that we can do is really be aware of the worst outcome or the poorest outcome that we're really working against with hepatitis B or any liver disease is a cause of death, correct? So patients can die from liver disease with decompensated liver, a really beat up liver from cirrhosis, or they can die of liver cancer. And that's what we don't want to see happen. So if you find liver cancer early, like any cancer, it's much higher rates of treating it. And so it's important that all patients living with hepatitis B and patients that have significant fibrosis from hepatitis C, even if they've been cured of hepatitis C, if they still have a damaged liver from having had hepatitis C, it's important that they have a lifelong monitoring for cancer, for hepatocellular carcinoma. Like I said, all patients with hepatitis B should be on a schedule, and they don't necessarily need to go to the hepatologist for that every 6 months, but with their primary care providers should have a schedule of being surveyed. And that's most likely with an ultrasound every 6 months and a blood test, an AFP. So this is a slide from Dr. Gish that we've talked about before. There's different recommendations for cancer surveillance depending on the organization, but in general, an ultrasound every 6 months is the recommendation. The last question in the last slide is, can damage to the liver be reversed? I'd like to hear from anyone on the call if they have any suggestions about whether this is true. From my experience, if people stop drinking, there can be a significant reversal of some liver disease. But in general, if someone has significant cirrhosis, it's usually something they'll be managing for the rest of their life.
Katie, we had an interesting comment from, I think, Okindo from, I believe, Nigeria, and he mentioned aflatoxins. I don't know if you have any comments on that, or if Jesse might be able to comment on that.
I do not have a comment, but maybe Jesse will.
Yeah, aflatoxin can certainly increase risk of HCC. We don't see it so much in the US as a primary exposure, but certainly worldwide that is a potential risk factor. And when seeing your patients from who are born from other countries, evaluating that potential exposure may inform your subsequent monitoring for HCC, particularly if they're in a gray area.
Yeah. And then another comment, does medical marijuana use come up with patients? And if so, is there a safe dose? Or do we even know at this time?
Depending on the drug screen, it can or can't come up, but I don't think there's any mal effects on the liver that I'm aware of, unless it's a very high intoxication dose.
And then one thing that I appreciate the general liver health tips. One thing that we say at the Hepatitis B Foundation to people who reach out to us about liver health is, the basic things about like maintaining a healthy weight, a well-balanced diet, avoiding high-fat foods kind of thing. I know Dr. Rothstein says coffee can be good for the liver, and sometimes antivirals too can help reduce some of the inflammation that's been caused over time for hepatitis B. So it's another couple other tips as well for hepatitis B space and liver health.
Yeah, those are excellent. Thank you.
Awesome. Any other comments, questions from the presentation?
Katie, I'll just say that was phenomenal, and I think really provides concrete tools for primary care, a comprehensive evaluation for liver health overall. I think some of the things that pop up, much to Catherine's comment, a nutritional consultation for people who are either living with cirrhosis or trying to really do all they can to improve their overall liver health, as has previously been mentioned. Fatty liver, hepatic steatosis is so common in our patient population, and to your point, there's so much overlap now that we're seeing in hepatitis B, fatty liver, triple infection with HIV, Hep C, Hep B, that's likely becoming more and more of an intervention, in addition to substance use disorder treatment, as well as alcohol use disorder treatment. The other aspects, I think, decreasing barriers to treatment. So you mentioned who should be treated for Hep C, everybody, and however, at any means necessary, I think. And so I think the tools that you've provided are really exceptional, and bringing vaccines to patients where they are. Oftentimes, primary care providers don't necessarily have a full array of vaccines available to their patients, and increasing the availability for Hep B, Hep A vaccines, certainly in the primary care setting, can improve that. Coffee was the only thing I thought of as far as improving liver health and may even decrease risk of HCC. There are some studies that suggest with cure of hepatitis C, a proportion of people can have reversion in their fibrosis, but maybe going from F3 to F2, not necessarily total resolution. So I certainly provide that as a cheerleading component in people who have cured, but highlight that work with fatty liver, maintaining healthy body weight, decreasing alcohol use. All of the recommendations that you had delineated are really key in helping longitudinally.
Thank you so much.
Thank you. Any other comments or questions? Great. Thank you so much, Katie. This was, like Dr. Torgerson said, a great presentation, and really a high-level overview of really things to consider for people, not just with hepatitis B, but also with Hep C. So I definitely appreciate that and think it was a great session for us. Awesome.